Okay, and we are live and recording. So I want to welcome Dr Erin Bowe, who's a psychologist in Australia here, who I've known for a really long time.
Yeah.
And we're talking today about birth trauma. So Erin has worked in the perinatal space for quite some time. Now, Erin, I'm going to be really embarrassed in asking this question because I actually cannot remember, and please forgive me for this. Did you do a placement with me before you joined our practice?
It was technically with you when you were, many moons ago, the placement coordinator, and you were running or helping to run the uni clinic.
Yeah, okay. Because I sort of had this vague feeling. So Erin used to live in Tasmania and has worked in my practice a long time ago now, 8 years ago, something like that?
Longer.
Something like that, maybe longer. And now it's based in, whereabouts? You're in the country. You're in Victoria. You've just had your vineyard smashed by a tree. I understand this is the rural life that you now live.
Yep.
Surrounded by chickens and babies. It's very exciting. But Erin has become known very much for working in the hypnobirthing space and is now moving into working more around the birth trauma space, specifically focusing on birth workers. So for our perinatal training participants, we're having a little chat today about those ideas and then also sharing this audio later on with our podcast audience. So welcome to all of you. Erin, do you want to let me know how your perinatal therapeutic journey, I guess, working in this space, how that came about? What set you on that road?
I'll try and make it short because I can.
Okay.
I thought about this. So long story short, as you know, when you're trained to be a psychologist, that takes up like loads of your time. And so babies kind of get pushed to the background until such a time, funnily enough for me, when I went off the contraceptive pill while I was working at your practice, actually. We're getting all personal.
Why not?
Anyway, long story short, I had to come off it because I had a small stroke. And once I came off that, suddenly all I could think about was babies. I wasn't ready to have my own, just very interested in them. And so I think part of the attraction to perinatal work was partially because of that, for personal reasons, but also I really liked seeing, I suppose, the outcomes when there's like a little, not just like a couple, but like a triangle of people involved. So usually mum, partner, and a baby. And I kind of liked that little dynamic to work with. So I did that for a while. I don't know how many years. Anyway. And then I was the sort of person, I always tell this story to my hypnobirthing clients. So I'll just kind of rehash.
Sure. Yeah, sure.
I used to be the sort of person who's like, yeah, give me all the drugs. I don't like pain, not interested in that. My husband probably read way too much science fiction. And so he used to talk about this idea of, we'll wait until, technology improves and we can have what he liked to call baby in a can. Meaning like an artificial womb of some sort of, too much science fiction. But anyway, so we were both very like highly educated type people thinking like, yep, technology is the way to go. Absolutely. And then I thought, okay, I'll do a bit of prep once I was pregnant. And I watched this movie called The Business of Being Born. You seen it?
Yep.
Shouldn't watch that when you're pregnant. Don't watch that. But anyway, I suddenly went from going, oh my, no. Okay, I was going to have all the drugs and all the intervention and all the technology, and now I don't think that's a good idea.
Yeah.
So I thought, okay, think about this logically. Which has nothing to do with babies really, but it sort of will make sense when I talk through it. My research background was in self-harm and self-injury, because again, me being the biggest wuss in the world, thought that was a behaviour that I found fascinating because I'm like, I just cannot imagine doing that myself. So I'm going to study this. And so from that study, I guess I knew the brain is like this amazing 24-hour pharmacy full of loads of wonderful natural drugs, if only you know how to open the door and get in. And so I thought, backtracking, there's got to be something in this. What can I use from that to apply to birth if I don't want to take all the drugs? And it's not so much about whether you take the drugs or have the interventions or not. There's a lot of reasons not to. And so around that, I found hypnobirthing. I'd heard of it before, kind of actually dismissed it as something like hippie weirdo type people did. Bit of kumbaya and, I don't know, being centers and
bit of woo-woo.
very much on the woo-woo. But then when I looked into it, because another mutual colleague that we know was teaching it, and I thought, you know, she seems like a reasonably sensible person, definitely a little bit more hippie than I am, but I thought, okay, there's something in this. And being the massive overachiever that I am, I thought, well, I can't just take a course. I'll train to be a hypnobirthing practitioner, because this is another weird thing I do when I'm pregnant. I take on more courses. Some people like to do DIY. I take courses. So I trained in it, and I said to myself, right, I will try myself out as a guinea pig, and if it works, whatever that means, I'll teach it, and if not, I'll just put it down to some PD that was, you know, a thing that I did. And so I'm super, super glad I did it, because it just is so research evidence based. I think even if you are so woo-woo, or even if you're like kind of like woo-woo curious, maybe, so I was, but much more science-minded, it actually just makes so much sense. And it brought together all that stuff that I had already learnt about and understood about the brain chemistry and mind over matter kind of stuff.
So what is it in a nutshell? I mean, it's you. I won't try and describe it. What is hypnobirthing in a nutshell?
There's different programs. I guess it's kind of important to stress. Look, I kind of think people just gravitate and find whatever course is useful for them. The one I've trained under, the Hypnobirthing Australia program, is a combination of teaching you how to relax, essentially, how to use conditioning to sight, smell, touch, sound, all that kind of stuff. It's all that kind of conditioning yourself to a thought. So conditioning yourself to just automatically, yep, you're going to have a positive birth. It's not about saying you're not going to have pain or anything like that, but it is getting you in the right mindset so that all those wonderful neurotransmitters, endorphins, can just do what they naturally are primed to do if the fight or flight response is not triggered. And then alongside of that, there's a lot of really good training about the hospital system, the home birth system, what does an OB do, what does a midwife do, what does a doula do, and it trains up your partner in how to actually help you, which I like. Yeah. So there's a whole section just for the birth partner to learn, okay, what do I do? Because we've got this culture, not just in Australia, but so many places where men typically, because they are typically the birth partner in at least the couples that I work with in that sense, they just are like, oh, I don't know, they've kind of just got their horror stories that have been passed on, or they don't really know anything about birth. They've just got...
And there's that sense too of helplessness, you know, watching a partner. And I know that my husband talked a lot after my first son was born, just about witnessing me in so much pain and being completely unable to do anything about it. Yeah. And I think for a lot of men, that's actually quite a challenging space to be in, and they don't talk about it an awful lot.
No, because in any other context in the world, if you saw, and I mean, this is what happens potentially in a traumatic birth, if you saw your partner spoken to rudely, handled roughly, made to feel like she had absolutely no locus of control, no choice, held down, cut, like that's just not a natural set for the brain to go, okay, I'll stand back and not do anything. So that stays in your cells for a long time, unless we kind of help people navigate their way through it.
Yeah, that's exactly right. I mean, we're going to talk more about birth trauma in a minute, and I think it's really important while I've got that thought in my head to acknowledge that birth itself is traumatic enough. and so for a partner who doesn't know what they're seeing, or even for obviously for the mum's in a different headspace, I guess, but for partners in particular and other birthing family members and whoever who might be witnessing that, especially if they haven't seen it before, it's a traumatic enough thing to bear witness to. The whole process and that sense of helplessness as well, let alone when things go wrong, in inverted commas, whatever that means for people. And for some people, I know it's just your birth plan didn't go to plan, and for others it's, you know, catastrophic wrongness about the birth and the birthing process. You mentioned midwives, you mentioned doulas, you mentioned partners and obstetricians, and these are the key other people involved in birthing. Do you want to give people a very quick sort of introduction of what those professionals are doing in the birthing suite? What would you normally expect? I like the giggle.
I guess if you start, I hate to think of it as like a kind of food chain top down kind of thing. It's like how we have in psychology. There's like, oh, a psychiatrist, and there's a bit, yeah, you're above us and we're below you and all that sort of rubbish.
Yeah.
Essentially, you've got an OB who is a trained surgeon. So in the traditional sense, an OB should typically come in when there is a high risk birth. They're trained to look for emergency. That's what their expertise is. Well, we have a weird thing in Australia where if you want to use private health that you've paid a fortune for, you have to have an OB, even if you are the lowest of the lowest of the lowest risk pregnancy. It's just a weird quirk that we have. So lots of us, myself included, I'm like, well, I've paid the money for the private health. Yeah, I'm going to do that. I can't have an OB, which, you know, thank God we have them. But we have a massively overskilled, I suppose, set of people who are hanging around attending births that isn't exactly what they signed up to do. And some of them are very pro-physiological birth and some of them are quite anti-physiological birth. And they want to stay in their comfort zone of surgery because that's what they're trying to do. But that's sort of, yeah, what they're meant to be doing, surgery. But a lot of them are kind of just doing run-of-the-mill stuff that the midwives should be doing. Midwives are essentially experts in low-risk regular birth. I've been doing it for eons and eons and eons of however far back you want to go. But they typically will be the ones there doing all the legwork, so to speak, before showtime, because OBs turn up when the baby's crowning, usually. And then you have potentially, there's doulas as well. So a doula is a non-medical person who's, I guess you could call it like a birth coach. It's someone there to support mum and support her partner and support baby through to whatever stage of pregnancy right through to postpartum. And they have a very, very wide-ranging role, wear a lot of different hats. And they're often, I think, by a lot of people misunderstood as to what they do, but such a pivotal birth worker role in the birth space, in whatever space that looks like.
So what sort of professions do they usually have behind them, a birth doula? Like, do they come from a counselling background or a social work background or nursing background, or?
They can come from any background.
Anywhere.
So a doula is, at least in Australia and actually pretty much everywhere, I don't know anywhere where it's regulated. It's an unregulated profession, which has pros in that they don't have to do all the APRA stuff.
Yep.
Hanging over them. Cons as in you might have someone who's done a really intensive, great doula training background. You might have someone who's done a 6-hour course.
Yep.
It just depends.
Yep. Okay. And so are they well respected in Australia?
Depends who you talk to. In my world, yes.
Yes.
In my world, they are the absolute rock stars of birth. These are the people who are the game changers, who take that level of support from potentially non-existent to they just change lives. So they're kind of, a friend of mine has, I don't know if she probably didn't coin the term, but I always think if everyone uses this term, she talks about doulas and birth workers as being like emotional first responders. Whereas you and I, yep, we've got lots of training in, you know, perinatal stuff and birth trauma and all that sort of stuff, but we're maybe third, fourth, fifth person that somebody sees if they're in distress. Yep. Whereas a doula's right there and has amazing potential to help that couple and that woman through, you know, a not so wonderful birth.
And I imagine for couples that they actually are, in my mind, I see them as creating like a bridge, because the father is typically father, but the partner is often, you know, to the outer. In fact, my husband, there's a great story about the birth of my husband. My husband was 13 and a half pounds when he was born to a very little mother. Yeah. And his father, this is 1964, so his father was outside pacing the hallway waiting for news. And the midwives who in that particular hospital, I think at the time, were also nuns, and this is a Catholic family we're talking about, came marching out. Simon was born, all 13 and a half pounds of him, and the midwife came.
11.3, that's amazing.
13 and a half. And he actually held the record for the largest baby ever born at Box Hill Hospital until, he likes to say, until the Samoans moved in. But for a while anyway, he held the record. Anyway, so the midwife came marching out and just basically bailed up my father-in-law and said, how dare you do that to that poor little woman? Like, it was his fault. Not only was he excluded from the process, but he was also blamed for the size of the baby, and then it was a bad thing. And of course he's still left there with all this, like, well, what, oh my God, what has happened to my wife, and what's going on? So partners are often to the side of things, even in the best of circumstances. And I kind of imagine that the doula is keeping eyes on both mum and dad, and making sure that they are the bridge connecting this triad that's emerging with the baby coming, and all of that sort of stuff. And I can imagine they'd be great for that emotional adjustment as a couple, postpartum, because it's such a difficult transition for couples to make, especially after their first child.
Again, but if I did, I would not birth again without a doula. So I didn't have one first birth, had one second birth, wouldn't do it again without one.
Yeah. Wow. Okay. So you've spent a lot of time running hypnobirthing classes for expecting parents, and is there anything that you can share about that journey for you as a mental health professional? Obviously we typically assume the one-on-one, and a big part of the point of me running the perinatal training was about shaking up this idea of the one-on-one therapy and CBT people to death. But hypnobirthing, again, takes it to a next level. It's more than just, antenatal parenting classes and postnatal parenting classes. There's something else to it. So tell us about your experience of making that transition yourself as a psychologist.
I think for me, when I had my kids, I've got two who, they just hate sleeping, to put it mildly. So I knew I wanted to still do something in that realm, but I thought I cannot do a whole day of therapy clients or assessment. I need something else. And so this was nice because you've got such nervousness and excitement, but it's so positive. So you get people who are so pumped for the information. They're so positive. There's an amazing outcome at the end. So there was a bit of a chance to still use my brain, but a lot more lightness, I suppose, potentially than what we get when we're psychologists dealing with, anxiety, depression, PTSD, all that kind of stuff. So it was a nice, I guess a bridging kind of thing in between, because I'd already had my kids. So I started just after my first daughter. So a nice way of seeing just people from all sort of walks of life, but generally there's been a goal where people are seeing that this is, a huge event in your life, and it's got the potential to change your life, your couple's dynamic, your child's life, all that kind of stuff. So a good mixture of people. Like, I've had artists, I've had midwives, I've had nurses, I've had anaesthetists, I've had so many different kind of people come through with varying levels of expectations. So there have been the people who are really like, yep, I know what hypnobirthing is, and I know how I want it to work for me. And sometimes typically dads who sit there like, okay, I'm here, I'm being supportive, but like, what the hell is this that you've brought me to? And I think one of my most recent actual favourite moments was seeing a dad. His wife didn't actually tell him why he was coming. Something about, it's like a pregnancy class. And so he was so suspicious. And this is like a police officer, quite high up, very serious, very like. And so I think the best compliment I ever got from one of my classes from him was saying, do you know what, Doc, my bullshit rate didn't even go up once. So if I could print that.
That's a real compliment. I love it.
He was like, from the guy who was like, yep, okay, birth is dangerous, birth is terrible, birth is scary, I don't want to look at it, it's like your favourite pub burning down, all that kind of stuff, which is sometimes pretty typical, to being really involved and really excited and a lot more confident and a lot more relaxed, kind of like, oh yeah, all right, I can do this. This is like not necessarily a scary medical procedure, and my wife's not sick. This is like, I've been doing this for eons and eons.
That's right. I think Yeah, I love that. Yeah, I hate it and I love it in equal measure. That saying of, you know, favorite pub burning down. You know, that there's a lot of negative assumptions around, you know, the ruining of a woman by becoming a mother. And I think that things like hypnobirthing, of course, go a long way, and a lot of, you know, the more modern movements around perinatal and antenatal particular care for dads in particular is doing, I hope anyway, and I'm hoping you're seeing this play out in your courses, doing a bit to actually reinforce the notion that your wife is, you know, not ruined. Your wife is still your wife. She's still the same woman she was. She's now also a mother, and you're also a father. Do you see that play out with dads in the courses, that their attitudes shift? Do you see much? I mean, obviously it did for him, but is that a common experience?
Yeah, and it's actually one of the things I love the most. Sometimes it's the dads who then refer their friends, and so you sometimes see a dynamic that you wouldn't typically expect. We kind of typically expect, oh, to be the woman who tells her friends and then her sister's done it and whatever, but these are the guys who are in the pub later on going like, this is amazing, it's phenomenal. You have the chance to see your partner, the strongest, most empowered, like just powerhouse that you've ever seen. It's amazing. So it has this real potential to deepen your relationship and just do amazing things for men as well, to not see it as this scary, terrifying thing where they are, as you said before, like on the sidelines, not able to, they're just, you know, sort of vicarious witnesses, I suppose.
Yeah, bystanders in a way. Yeah, and it's like we said before, you know, quite invalidating for their role as helper to their partner and saver of their partner and fixer of all things broken, I guess. So if people are interested in hypnobirthing, like if clinicians are interested in finding out more about incorporating hypnobirthing into their practice, how would you recommend they go about doing that?
My plug is always going to be for the Hypnobirthing Australia program, because it is Australian. All the tracks are in an Australian accent. It uses all our hospital stats as opposed to American and UK hospital stats, which are a bit different.
Yeah.
It's something you can train in if you are, say, medically trained like a nurse or a midwife, or you can come through it like the route I did if you're a hypnotherapist, therapist, psychologist. You just kind of need to do that extra little bit of, I suppose, the medical side of the perinatal stuff. So, you know, the uterus, how it all works, the mechanics of stuff. And as I said, it's a nice adjunct to add to your practice, because clients can, if you're a clinical psychologist at least, clients can still get a private health rebate for attending.
Yeah.
So
I think that's a good point actually, because part of the perinatal training program will cover off a little bit on you know, making it all work in private practice, and of course one of the things to consider is Medicare. And I know I'm going to get asked, can we incorporate any of this under focused psychological strategies? Would you feel comfortable, if you were not a clinical psych, because I know you are one like me, would you feel comfortable incorporating this under psychoeducation? And under what circumstances?
I think there's bits of it you could take, but it's tricky because you're talking about quite, it's a quite specialised set of skills. Leading people through hypnosis really is a specialist set of skills, and whilst you don't need to be a clinical...
And hypnosis isn't recognised as one of the focused psychological strategies, is it? No.
No.
So would you'd recommend that if clinicians are wanting to run these groups in their practice, that they actually just market them without Medicare being a consideration, generally speaking?
Never put it through Medicare, and I know even midwives who run this course, whether it's out of their private practice or through hospital, aren't able to claim through Medicare either.
Yeah, and they still have a successful practice doing it, so Medicare is not the be all end all. Yeah, good.
Yeah. This is the thing, outside of psychology, you know, we forget not everybody's looking for a rebate.
Yeah.
Every single step of the way.
That's an interesting thing. I think, you know, most people, especially in the perinatal space, people are looking for help. They're looking for help in feeling less anxious about what they're approaching with having a new baby. They're looking for help in adjusting to being a parent. They're looking for help in you know, all the other, let alone the anxiety and depression, but all of those, the multifaceted thing about becoming a parent. People are out of their depth and they're desperate for good quality care and good quality education support. And I think we get hung up, can get hung up on things like Medicare, when actually that's not what the clients are looking for. They're not fussed so much about that. They just want to help.
You just hang out with doulas for 5 minutes. None of them have got anything that's rebatable for anything. And people are very interested in hiring a broader spectrum of people. Like, you'd be surprised. In our world, we are so focused on how am I going to get clients if there's no rebate. If you take yourself out of that bubble, it's phenomenal.
Yeah, exactly. All right, so now let's talk a little bit about birth trauma. So what sort of things would you normally be thinking about when you're talking about birth trauma? What sort of experiences are we talking about here?
It's the how long's a piece of string. It's, you know, that eye of the beholder kind of stuff. So a lot of people focus on the physical trauma. Like, for some people, even the word trauma means like physical injury to the body, but it is whatever a birthing woman person says, yeah, I don't feel okay after that. Whether it is something that the rest of everybody looks at and goes, oh, well, that doesn't seem particularly traumatic. It's no different to any other trauma in the sense that it is subjective, because it's got to take into account your history with your own body and how that body has been treated by other people potentially, how much control you had, how you were spoken to, how you were treated, the health of your baby, the health of, like, there's just so much stuff, so much to take into consideration. I think the major thing that people forget to do is actually just ask about the birth and jump straight to, oh, well, it must be depression, or it must be anxiety, or it must be something, without actually looking at that massive event that is birth.
It's such an important point, and I just want to, I guess, reinforce, you know, to guys listening, that asking about the experience of becoming pregnant and the birth itself, the pregnancy itself and the birth in particular, and what that was like. So I would say in my perinatal practice, the most common form of birth trauma, and I use inverted commas because I acknowledge that this is not going to sound like a traumatic event to other people. The most common birth trauma that I work with is typically medical professionals of some form or another who have what they describe as a failed experience of birthing because they haven't birthed perfectly. There's been there's been a tear, or they've had to use some kind of drug, or there's been some other form of intervention or whatever, and they had in their minds that to be a health professional having a baby, I should be able to do this perfectly without any kind of anything going wrong. And that's such an interesting bunch of issues to unpack. So I'm quite with you there. You know, that whole idea of the eye of the beholder, like how was it experienced? Because we all often say, were there any, you know, was it a straightforward birth, any major issues with the birth itself, but we might forget to say, and how was it for you? And I think that, you know, because there might not be any major issues in terms of, I don't know, emergency Caesars or anything like that, but it still might have been quite a difficult experience for the parents.
I mean, for some people it can be, you know, that changing of shift with staff that come in, and just, you didn't like the way that somebody made you feel. You didn't like, I mean, this is the thing about that. You are physically the most open that you're ever going to be. So you are physically vulnerable, you're emotionally vulnerable, you're psychologically vulnerable. And you're highly, highly, highly suggestible as well, just because of the, you know, going into lizard brain. So, like, we have to be really, really mindful that for anybody can go a way that you kind of, you know, don't expect things to go, in terms of, it doesn't matter necessarily what was said, but it was like, how did it make you feel? How did that person make you feel? And did you feel, you know, like the typical things that I hear about are the pressure that, this is taking a bit too long, when really there's no time for how long birth takes. But it's all the bureaucratic stuff that slips in.
Changing shifts is an issue that comes up a lot when, and you would know this also from working with birth professionals, that changing shifts actually is a major thing in the hospital and the system. It's a system issue. was going to say, add to that, people's expectations around who is present. So for some people, their birth experience might be, we'll use the word traumatic because that's what we're talking about here, because the obstetrician wasn't present. And so they feel perhaps abandoned, and that then makes them feel more anxious and all the rest of that. My second child was delivered by two student midwives. And my obstetrician arrived in time to deliver the placenta, and that was fine. It was actually quite a great birth, that one. Well, they both were. But I think when we're dealing with birth trauma in those who are observing or participating, not just the mum per se, but so that's the work you're doing more of now. What drew you to that in particular? How'd that come about?
Enough. Yeah, so you're going back to talking about massive babies. So I had a massive baby too. I'm 5'4", that was, I don't know, 50 kilos-ish. Massive baby. She was 5 kilos on the dot, which is 11.3, I think, if you convert it.
Yeah.
I kind of was told along the way she was going to be a big baby, but I didn't, get too excited about it. My OB didn't get too excited about it. And then on the day of birthing, I'd had prodromal labour for weeks. She was sort of trying to descend and obviously getting stuck. So she did get stuck. She had what's called severe shoulder dystocia, which means shoulders got stuck. And usually, there's a couple of different moves that you can do to freeze stuck shoulders, but this little poppet had shoulders like concrete, as my OB described it, and all the typical moves that you would typically do didn't work. And so there was like 5, 6, maybe even 7, because I can't quite remember, really sort of invasive manoeuvres to get this baby out, but, got around. But I suppose, like, as I said, so I had a doula and she was an amazing support, like on so many levels. But I had the cheap seat, as I say. I had my eyes closed. I wasn't witnessing all the, things that were unfolding. It was in like 3 minutes, because when you've diagnosed shoulder dystocia, you've got 5 minutes before there's hypoxia and nerve damage and all sorts of, quite scary potential things that can happen. So it was a 3 intense minutes, but geez, yeah, super intense. And she was watching all of this unfolding and really feeling for me and my, I suppose, distress. I feel like it was distress, but it was, for me, managed distress. It was like, okay, I'm just going to focus on the breathing, just get this baby out. I hadn't even noticed that the baby was blue and the cord had been cut and all that sort of stuff, because the relief I felt of having that body out of my body, like, it took me a little while to come around. And then there was definitely a period of dissociation for me, whether that was intentional or incidental, I don't know. It was kind of useful for me at the time though, because I could just check out for a bit, and how people have that experience where they talk about kind of like looking down on yourself in the room. So I got to experience all of that sort of stuff. But for me, it wasn't scary. It helped keep me quite calm and quite removed. It was only sort of later. But anyway, and then I did all the things that I knew in my training to do to activate the hormones of birth, so all that psychophysiological stuff, get the oxytocin in, sniff, kiss over that baby to get that high that I didn't get in my first birth. When people used to talk about the oxytocin high, I don't know what you're talking about, because I was pretty traumatized after my first birth. And this time around, I was kind of like, no, I'm not having a pity party. I was really like determined this is going to be different. So I got the amazing oxytocin high because I didn't have any of the drugs or any of the interventions, and it was amazing and I felt great. And people kept saying, are you okay? Are you okay? I think I am. And then I kind of, enjoyed my baby and questioned a bit. Like 24 hours, like, yeah, I actually am okay. But my doula was not okay. She had to step out of the room for a little bit after. And she was just, I could see, she was really proper traumatized. And so while it was not my job to care for her and wonder about her, of course, like, I got to go home and get on with the fresh new baby. And I felt perfectly okay. And I went through all the moments of like, is this denial? I'm like, no, actually I'm okay. But she wasn't. And I remember thinking to myself, God, like, she has to go back in her car, drive back home to her kids, whack a smile on her face, pretend to be fine so that she can be okay for other people.
Yeah.
And where is the support? Where is, like, I had a nun, I think at one point, pop her head into my room, and I wasn't even there. I was in the bathroom or something, and that was the support for me. And whether that's because I seemed okay and I wasn't offered lots of support, or whether that's just the way it is, but for our birth workers, there's nothing. And the more people I talked to, the more this picture started to unravel of like, the people who are doing the supporting have not got any support, particularly because, you know, they're not, I don't know, I don't kind of want to put it like this is the right way to do it. It's just one way to do it. But with us being psychologists, it is regulated, you have supervision. So we know that that is there to kind of check in for our self-care and our practice and all that kind of stuff. But when you're not obligated to do that necessarily, you kind of have to figure it out for yourself, which is not the way it should be. So yeah, watching that unfold and watching that unfold for her, knowing how pivotal she was to making that birth a good experience as much as it could be for me, seeing how traumatized she was by it, I just thought, oh, I need to do something about this. What can I do? And so that kind of propelled this whole next bit of, I think this is where my journey is going. It's not something necessarily that I chose, but everything is like screaming at me, hey, if not you, who else is going to do it?
I think we've got to listen to that sometimes, you know, when all the arrows are pointing in the same direction and that inner voice is just yelling at us to please take this opportunity and run with it because it's your passion area. And it might be that something in our personal lives has triggered that passion area, or it might be that we've just accumulated over the course of a career enough experience and interest in something that it becomes a passion area by stealth. I think you've got to listen to that when it yells at you. It's so important. I think it's exciting. I'm really excited for you actually to be doing this work. And so, I mean, what's been, I know you've only recently announced, because you do most of your social media work on Instagram. I know it pops up on Facebook as well, but you're pretty active on Instagram. And I saw that you announced that you wouldn't be doing any more of the hypnobirthing because you've made a very deliberate decision to put all your energy into this. So what was the thought process, you know, to close off something that had been such a big part of your perinatal work so that you could put all your attention, because I know you've got 2 small kids and so you've got limited attention to offer. What was it like making that decision and then making that announcement?
Terrifying. Mm-hmm. Like absolutely terrifying. And I went through, like all good decisions, a process of being adamant that no, I'm not doing this. I don't want to do this. How am I going to go on Instagram and talk about birth trauma? This is depressing. Who wants to listen to this? This is miserable. This is too narrow. You know, I'm a Gemini. I need to be doing too many things at once. How am I going to narrow my focus? And that's, I think, you know, I think when you talk to lots of different people who are known for one particular thing, that's a process that everybody goes through, that you have to go, no, I'm quitting. I'm not doing this. I don't want to be known for that anymore. But, you know, you can always pivot, I suppose. You can always change your mind. You can always backtrack. So I kind of did all that bargaining and negotiating and all that kind of stuff. And it just came down to the fact that, again, being the overachiever that I am, I'd set myself like, right, this is how long it's going to take me to film this course, edit this course, get it out, get it done. And like best of intentions, like, you know, those of us who say, I'm going to get my PhD done in 2 years, 2.5 years. And it probably doesn't work out like that.
No.
So, factors that are beyond our control. And it didn't happen. And I just thought, oh, it's so disappointing. But to get this one project out, I do need to narrow my focus because I've got, as you say, 2 young children, other things happening. So it was kind of like, I need to just go eagle hawk focus and do this one thing.
Because you're based in a rural community, aren't you? I mean, what's your closest city?
I'm sort of smack bang between, you could either go to Bendigo or you could go to Melbourne. So I'm in the Macedon Ranges. So I guess Sunbury, but yeah.
Yeah. So you've built this successful business and you've got, you know, a social media profile that, I mean, people will say, I've got a social media profile. You've had a social media profile longer than I have, really. And I've been watching your, it's interesting you talk about, how do you talk about birth trauma on social media and not make it negative? I've been watching this very subtle but very proud shift, and I'm saying proud in how you're talking and I'm proud for you. I think it's so amazing. Just this little bit of attitude starting to creep into your social media posts. It was always there, but it's almost like because you're now focusing on something that you're actually advocating for, as well as working, you know, to help people, you're also advocating for recognition, I guess, is the byproduct of what you're doing. And yeah, there's this really fiery attitude coming through, which I'm absolutely delighted in watching unfold. There are even some swear words the other day. It was awesome. I can't remember what it was now. It wasn't that bad, but still.
What's the worst that can happen? Like,
this is it, you know. Mm-hmm. And this is what's so important. I think that when we, especially in the perinatal space, and I know we could say the same of any other clinical population, but I think, you know, for those of us who are passionate about working in the perinatal space, we have to get a bit of attitude sometimes about the work that we're doing and stand up and say, actually, you know what, this is the way we're going to do this, and this is what it's going to be. Whether that's our social media work, getting messages out there to the community, or even sometimes I find myself being much more directive with perinatal clients than I am with many other clinical populations. If I'm seeing someone antenatally and I'm concerned about what's going to happen postnatally, I'll be much more directive about what I want them to be doing in terms of coming back to see me, rather than being, you know, a bit more airy-fairy and let the client choose. Whereas if I'm concerned about how that's all going to play out, I'll make sure that I make a noise about it, with all respect to the client and very gentle and loving as well. But I think it's one of those areas where there's a lot of passion involved, whether it's the workers, and this is why, you know, this birth worker trauma is such an important area to focus on, because we get so passionate about it, because we're either advocating for unborn babies, or we're advocating for traumatized fathers who are being overlooked, or the birth workers who are being overlooked. There's just so much in it, in this particular field.
Yeah.
And
stats that are out there, like, it is a health crisis. 1 in 3 women have a traumatic birth, that suicide is the leading cause of maternal death, like that. Serious numbers. And yet funding gets cut. Like, I don't know, we could go on all sorts of tangents, but I suppose the thing I have come to accept, that's again the whole, like, okay, if not me, well, who's going to do it? I think part of our psych training, I don't know, it'd be interesting to see if you agree with this, is we're very much taught not to be seen. Don't inject yourself, don't share too much, don't, like, basically just be a blank canvas and assist, but like don't get in there too much and don't be seen. And that's not actually helping anybody. To just have a vanilla professional workforce who are all automatons and also the same thing, and don't actually have any fire to do something about the shit storm. There we go.
There you go.
You know, maternity crisis.
I think that's true. I think that's very much true, you know, and I guess that's probably why in my own practice I notice this directiveness that I have with this client population more so than with other clients, because there's so much vulnerability around this. We talked about that before, the vulnerability. And we are trained, I think as a professional body, we're trained to make ourselves obsolete, which is great. I mean, it is, that's what we should be. We shouldn't be making clients overly reliant on us, but it's really sort of pushed. It certainly was when I went through. You know, your job is to be there to provide some tools and let the client take them up or not take them up, make yourself obsolete, don't have an opinion on anything, and certainly don't disclose anything about yourself. And in fact, I know from your both talking to you, but also your social media work, you disclose a lot about your own experience. And I know in the consulting room, I disclose a lot about my experience too, because one of the key aspects of our role is actually normalising this experience for people whose lives have just been picked up and turned upside down and given a bloody good shake, which is becoming a parent. That's what it is. You know, and you think that you're going crazy when in actual fact, a lot of what you're experiencing is just part of the normal transition. Sometimes it's more than that, but oftentimes it's part of that adjustment process, and to normalise is really important. So yeah, our training does set us up to play a little bit of catch-up footy, I think, sometimes in this field, in terms of put that aside, do what is right for this family, do what is right for this baby, use your evidence-based platform for your practice, but don't be so shy, don't be so afraid to have an opinion and to put that out there, whether that's in the consulting room or on social media.
Birth is so personal, and I think it's very difficult to do that, sit by the sidelines and not inject anything when you're, you know, on the other side of it. Like, really private, personal conversations. Like, you know, people invading your personal, private bodily areas. Like, what's more personal than that? So, yeah.
Yeah, that's exactly right. It is exactly right. Well, I'm very excited. I'm very excited that you're doing this work. I think, you know, that whole message of if not me, well, who, you know, and it's not about whether or not you're the only person doing this work, but if you're called to do this work, why wouldn't you? And I think it's you know, we've sort of touched in a previous conversation via email about on you know, bullying in this profession as well, in terms of, you know, the birthing profession, and that's something we might talk about in another time. But there is an expectation on, especially midwives, I think there's a huge expectation to pull themselves up by the bootstraps and just get on with it and not acknowledge their own emotional responses to the work that they do. So it's such valuable therapeutic work. I'm so glad you're doing it. Awesome. So now you're available for a little bit of supervision or a lot of supervision depending on what people need. So if this is an area that people are really keen to get either some, you know, one-off supervision or some ongoing from you, what's the best way for people to contact you?
Just on the website, probably.
Yeah. Do you want to tell us the website?
It's drerin.com.au.
And I'll put that, I'm going to put a couple of things in the comments section or the description section. So I'll give the link to Hypnobirthing Australia. I'll give your website. And people can also follow your Instagram. What's your Instagram handle?
I think it's at Dr Erin, or maybe it's at Dr Erin Bowe. One of those. It's the kind of thing I can rattle off when I've had a bit more sleep, but you know.
All right, I'll look it up and I'll put it in there. Is there anything that you want to add or you'd really, really love, especially people new to the field, new to perinatal work, that you'd really like them to take away from our chat?
I think just for me, like, even though I've been doing it for quite a while, I really was surprised that trauma-informed practice is not a thing. You know, even like through to an OB, through to a doula, there's really little to no training whatsoever. And I had assumed, as you do, that there would be.
Yeah.
And I think, you know, it's something important potentially for clients to know about as well, because, I mean, you cannot be all things to everyone and nobody would expect you to. But even just, you know, the basics of, well, like those nice guidelines that have come out recently for midwives about language to use. Things sometimes that you think are common sense are not common sense.
Okay. I don't know what, I haven't had a look at those. I don't know what the changes are, but I certainly know when my youngest son, who's 7, when he was born, the midwives were tripping over themselves trying to stop saying birthing. We're not allowed to say delivery. We're not allowed to say delivery. Yeah, so, you know, it's,
Kids are delivered, babies are born or caught or received or
yeah. So that was funny, you know, here I was, you know, in all my vulnerable labour glory, and they're correcting themselves on the words they're using. It's quite noticed at the time. So obviously, I'm hoping they're a bit more relaxed with whatever the changes are now. But it is about making everyone feel more comfortable with the experience and more empowered too, I would hope. All right. Well, thank you very much for spending some time with us today. So as I mentioned, this will go into the perinatal training group, and a bit further down the track, once that training program is finished, I'll also put the audio onto the podcast. So if you're wanting to get in touch with Erin, I'll have links to her website, drerin.com.au, so drerin.com.au, which is also on Instagram. And also the Hypnobirthing Australia website will be there for you to follow up if that's something that you want to have a look at for your own practice. So thank you for joining us. I'm going to finish off the recording, and then Erin and I are going to have a private chat about all of you behind your backs.